Welcome to Advanced Practice, where we brew insights and evidence to elevate mental health practice. In the previous episode, we explored methylphenidate-based medications, the first major stimulant family used to treat ADHD. In this episode, we turn to the second major stimulant family, amphetamine-based medications. While methylphenidate primarily blocks dopamine and norepinephrine reuptake, amphetamine medications work somewhat differently. In addition to inhibiting reuptake of dopamine and norepinephrine, they also promote the release of these neurotransmitters from presynaptic neurons. This dual mechanism increases catecholamine signaling in the prefrontal cortex and striatal circuits, improving attention, motivation, and behavioral regulation. The earliest medication in this family is dextroamphetamine, marketed as Dexedrine, introduced in 1937. Immediate-release dextroamphetamine typically lasts 4 to 6 hours. Treatment often begins at 5 mg once or twice daily, with typical daily dosing ranging from 5 to 40 mg. A major development came with mixed amphetamine salts, marketed as Adderall, introduced in 1996. This formulation combines 4 amphetamine salts to provide balanced stimulant activity. Immediate-release Adderall typically lasts 4 to 6 hours, with dosing usually starting at 5 mg once or twice daily and titrated up to 40 mg per day. In 2001, Adderall XR introduced an extended-release capsule using bead technology designed to mimic 2 doses taken several hours apart. Treatment generally begins at 10 mg once daily, with therapeutic dosing between 10 and 30 mg per day, providing 10 to 12 hours of symptom control. Another major milestone arrived in 2007 with lisdexamfetamine, marketed as Vyvanse. Vyvanse is a prodrug, meaning it is inactive until metabolized in the bloodstream, where it is converted to dextroamphetamine. This mechanism produces a smoother onset and reduces the potential for misuse through non-oral routes. Treatment typically begins at 30 mg once daily, with titration up to 70 mg per day and a duration of action of about 12 to 14 hours. In 2013, Evykio introduced racemic amphetamine sulfate as another treatment option, with dosing typically starting at 5 mg once or twice daily and titrated to 5 to 40 mg per day. Newer delivery systems have continued to expand flexibility. Dianavel XR, introduced in 2015, is available as a long-acting liquid suspension and extended-release tablet, providing an alternative for patients who have difficulty swallowing capsules. Adzenys XR ODT, introduced in 2016, is an extended-release orally disintegrating tablet that dissolves in the mouth without water. In 2017, Mydayis introduced triple bead extended release technology designed to provide up to 16 hours of symptom control, covering very long days for adolescents and adults. More recently, another innovation appeared with CellStream, approved in 2022. CellStream is a transdermal patch containing dextroamphetamine, providing continuous medication delivery through the skin. The patch is applied once daily and typically worn for about 9 hours, allowing patients who cannot tolerate oral stimulants to receive consistent amphetamine therapy. Across all amphetamine-based medications, the therapeutic goal remains the same: enhancing dopamine and norepinephrine signaling in brain circuits responsible for attention, motivation, and executive control. What differentiates these medications is primarily their delivery systems and duration of action, allowing clinicians to tailor treatment to each patient's schedule, symptom pattern, and clinical needs. That's all for today. Thank you for watching. In the next episode, we will explore non-stimulant treatments for ADHD. See you soon. Bye.